My name is Manos Siderakis. I'm a radiology resident doctor last year at the CVIR Endovascular Hospital in Athens. So we had a 51-year-old female patient referred to our department from the hospital surgeons to assess her clinical condition and imaging findings. The patient had been complaining about an intermittent left upper quadrant abdominal pain for the last few months. And what was shown on imaging on ultrasound and contrast CT scan was a 6.6 centimeters maximal diameter lesion on the upper pole of the spleen, which was mostly compatible with a spleen hemangioma. So the patient was then informed of the risks and benefits of partial splenic artery embolization, and with your written consent, we proceeded. So there were actually two main reasons we decided to publish this case. The first reason was the infrequency of the case, since there are only around 100 spleen hemangiomas in literature, and very few of them have been dealt with by interventional radiologists. And the second reason was to highlight the safety and feasibility of the procedure and encourage our colleagues to handle these cases, because otherwise these patients would lose their spleen. There are three main indications for partial splenic artery embolization. These are the abdominal trauma, hypersplenism, and neoplasm. So in our case, the goal was, and what we did, we hyperselectively embolized the branches that feed the lesion, the branches of the splenic artery that feed the lesion. And the goal was to do that as close to the lesion as possible in order to induce infarction of the lesion, and at the same time without affecting the remaining normal spleen parenchyma. We had also cone beam CT during operation time that assisted in depicting the three-dimensional architecture of the vascular tree. And embolization was performed using acrylic polymer microspheres of three different size ranges. And what was really interesting with this case was that what we actually showed, because there was a 2-year post-embolization follow-up, what we saw with ultrasound and MRI examinations was that there was a gradual shrinkage of the lesion. And regarding other specialties, we would actually like to spread the news among colleagues of other specialties that under certain criteria, that additional splenectomy can be replaced by a minimally invasive partial splenic artery embolization. So large hemangiomas have a high risk of spontaneous rupture and life-threatening hemorrhage. So it is recommended that hemangiomas over 4 centimeters in diameter are treated. And traditionally, splenectomy has been the method of choice for these kind of lesions. However, nowadays we know there is a well-established role for the spleen. It has a vital role in blood filtration and immunity. So whenever there is a choice for the patient to follow an organ-preserving treatment, we should give them this chance, this option. So besides that, splenectomy has some drawbacks. First of all, there is a overwhelming post-splenectomy infection, the so-called OPSI syndrome, which is a potentially fatal complication, which may happen within the first 24 hours. Splenectomy also often requires a blood transfusion, which is usually not the case for splenic artery embolization. Embolization can also be performed under local anesthesia, which is not the case for splenectomy. And additionally, pain, operation time, and hospital days, they are all reduced in the case of partial splenic artery embolization when compared with splenectomy. So, for example, in our case, the patient left the hospital 24 hours after the procedure.